Welcome to the Behavioral View. Hey everyone, would you like to get a CEU for this episode? Listen closely for the announcement of 3 secret words delivered throughout the episode. Take note of those words, and we'll tell you where to go to get your CEU when the show is over. Hi everyone, and welcome to the Behavioral View. If you are new to our show, my name is Shannon Hill. I am the editor-in-chief at CentralReach Institute, and I am unhappy with my hair today. I do not normally look like this. I have a rule that when something makes me uncomfortable in public, I go ahead and say it out loud. So there it is. I'm still the same person, even though I look like somebody totally different today. And I am with my regular panel members. Carrie Millico, what would you like to say about yourself today?
Well, I mean, if we're doing true confessions, I'm going to say my butt hurts. Like, I don't know what I did. Like, my tailbone is like sore. So, I feel like I've been sitting on a plane for 5 hours. I'd rather be standing up right now, but you know what? I can do this for an hour and a half. We'll be okay.
You want to stand and go ahead. You know,
That was good.
you might want to consider starting that story next time with your tailbone hurts, not your butt.
Tailbone hurts my butt.
Not the
Fair point. Let's be more precise.
Suggestion.
We also have Nissa Bennett. And do you have any complaints today?
No, I am here and I'm excited for the talk. I love my co-host on the show because we hear it as it is. This is how we come to our talks. It's so fun.
Absolutely. Yep. And we are very happy to be joined today by Dr. Rachel Taylor. Rachel, would you like to introduce yourself and make any complaints that you feel necessary?
Yeah, now I'm like this. Honestly, I was nervous building up to this, and I never thought the question that would make me most nervous is any physiological current complaints that I have. So I'm kind of like slightly taken back, but I appreciate it. I know everyone is kind enough to say thank you guys for having us here, and sorry, I thought I got those notifications off. Tell me if that happens. I really mean it. And I want to, on a personal shout out, Carrie and I have known each other for, I guess, are we at 20 years? I don't even know.
Yeah.
And Nissa and I were just talking. So to know that we have a shared history that goes back to the early 2000s in Chicago, no less, even though we're SoCal. And then Shannon knows I'm just always happy to see you, Shannon. And I was just telling the story yesterday of Gina Green, very, strongly telling me that I was at the wrong table and I needed to go sit at the table that had my name on it. And I had missed this part of the invited speaker shenanigans in New Orleans, but I was thrilled when I got to that table that Shannon was there. So looking back, it was an incredible conversation. So I'm just happy to see you guys and be here. Thank you.
Yeah, I have to say thank you to Gina Green and Carrie Millico for making sure that we became friends.
It was so terrifying, and if she listens to this, Dr. Green, you know my utmost respect for you, and I highly doubt you'll hear this, but like a flashback to 1998. I'm like, it came right up on me. Rachel, I was like, oh my god, okay, like that's literally. I'm not sitting in a chair with a young autistic child working on anything. No, I'm not. Okay, like, but that's what I felt like in the moment. So it's gonna always be very salient.
I love that. Well, typically we kind of dive into this with a soft question of the day, we call it. Sometimes it's behavior analytic in nature and sometimes it's just goofy. But because of something that I was watching, one of Rachel's presentations in prep for this, I asked if we could all just do our elevator pitch for people who do not know what ABA is. How do you explain it? What do you say ABA is? Nissa, you want to lead us off?
I will go first. This is my favorite. When I ran a practicum cohort at my last organization, we had this assignment. And we gave them a 5-minute elevator speech, which is very long because they stumbled, they were nervous, they had to do it in front of each other on Zoom. 5 minutes is not as long as most elevator rides or any that I know of. So it's typically 30 seconds or less. And I've, over the course of the years of running that cohort, have kind of dwindled it down. And also in having interactions with people in a bar, at a restaurant, who want to understand what I do, it becomes just, working to improve the quality of life of any individual who requires my services in any scope. So if that's working in health and fitness, which I do often, making sure that I'm helping them meet their goals in that capacity, or when working with individuals with autism or IDD, working to make sure I'm making differences in their life in some capacity. And that's really, it either has more questions that follow or people glaze over and move on.
I wish I would have put the timer on, because that was like really interesting, actually.
Yeah, that was really good.
I try to avoid it. I try to avoid it. Like when I'm on the airplane, I kind of just don't want to get into it because I do have to explain it. So sometimes I'll just say, oh, I work with kids, or something that's around there when they ask, or if I'm at a bar, when I remember in grad school, I'll be like, I'm in behavior analysis. And then they're like, it's like, are you analyzing my behavior right now? And they're like on, what's that one show? It's not CSI, but, Criminal Minds. Oh, like the behavior analysis unit on Criminal Minds or whatever. I'm like, I just didn't want to get it, but now it seems to be more common and people seem to know about it more. And so I say I just arrange the environmental variables to help people do the things that they want or need to do. Kind of leave it generally there. And then if they probe anymore, then I can get specific about examples in the work or workplace or, in school or with different populations. But that's kind of my one sentence, and I kind of leave it there and see what happens after that.
I am with you, Carrie, on the trying to avoid it because of people thinking that we work for Criminal Minds or that we are analyzing their behavior right here and now. But I guess because of some passions that you guys have heard me preach on too many times, I simply just say it's the science of teaching and learning. It doesn't matter who wants to learn, who wants to teach, what they want to learn, what they want to teach. A behavior analysis approach can help form that. What do you say, Rachel?
This has been very interesting. Thank you for giving me the opportunity to say it. And so everyone knows, I will admit, right before we started recording, I had one, not request, but I don't even think it could be a veiled demand. I think it was pretty straight up. If you guys will answer this first, that would be helpful. And the reason why I asked was I was curious because I've been struggling with this in particular the last few weeks, but then again, 25 years. So I was like, this is going to be interesting to see if people who I have a great deal of respect for, that I know have worked across many different settings and have also faced exactly what you guys brought up in terms of your personal lives, that I was curious as to where you guys had taken this. So I've been joking with myself lately, all up by myself. It's really fun in this little world that I live in this converted storage shed, that I was happy that you didn't say what's the definition of ABA, right? Because I've realized lately when someone asks me that, I've had a tendency to be a little snarky, and I don't mean to be, but I'll say the application of the science of behavior analysis. It's really amazing how quick the translation can be, right? Okay, so or applying behavior analysis. I know it seems funny, but the reason why though is I go down this path then of saying, all right, we're at a point now of, and I don't know how valuable this is. I'll be honest with you. It's valuable in my little world of 25 BCBAs and 200 plus employees, and just how our conceptual framework of what we want the people I work with to feel about the science in the field. But I don't know how important this is, so I'll try and make it quick. So I would be silly and say it's applying the science of behavior analysis. Now, I recognize that it's important now to say as a profession, we got to take that definition a little differently, and not differently, but we got to build on it. So I would say that as a profession, our job is to improve quality of life. So I was interested to hear, Nisa and Carrie kind of come around that topic. We all know that's incredibly valuable. We also know there's a lot of discussion, concern, work to be done on how best to define quality of life, right? And that circles me back to the old school, not old school, they're still out there. By the way, if you do a little search, part of the problem in our field is probably the fact that every major website defines ABA differently. Just want to throw that out there for you. It's very interesting. I've done this search a few times. And we have to talk and recognize the fact that people do not know what we mean, obviously, when we say the science of behavior analysis, that there's actually a difference between the science of behavior analysis and the science of human behavior. And to be a behavior analytic practitioner, there's additional ethical obligations. So I would say that ABA is applying the science of behavior analysis. And that I would also say that if you are a behavior analytic practitioner, you're relying on a foundation of behavior analysis. And this is not my quote. This is actually from the latest update on the BACB. And you're doing that to maximize desired outcomes and minimize risk. And then we get in the game of, all right, what are desired outcomes? Now we can say that's quality of life. And now we still have kind of the same problem. And I'll leave my geek fest for you here, which is when we go back to all the definitions that we learned about what is ABA that are still out there, you see a difference in the use of the terms socially significant, socially valid. And what my colleagues and I have really shifted to lately is saying socially meaningful behavior. And we say that our job is to maximize desired outcomes and minimize risk towards an improved quality of life or towards socially meaningful behavior, which in turn means an improved quality of life. And if we really geeked it out and you looked up the definition of validity and significance, those are important things, but meaningful should be able to capture both of those things, because that's a matter of, are we doing what we said we were doing, and whether or not we can say that what we were doing had the greatest effect on those positive changes. So those are real specific things. So anyway, I know I took way too long, but I will say that a behavior analytic practitioner's job is to rely on behavior analysis to maximize desired outcomes and minimize risk towards that. That's how I look at it. If that made any sense, does it?
Absolutely. And this is actually, no, you make perfect sense. And usually I do lead off by saying what we invited you here to talk about. I didn't do today. But we brought you here to talk about case conceptualization. And I think what you just said folds nicely into, it's a good lead in for jumping into that conversation, because I do think that what you think of as your job as a behavior analyst would seem to impact how you go about case conceptualization.
The science of human behavior tells us why people think, feel, do, and act the way they do, and under what conditions they're more or less likely to do that, right? Worded differently, Shannon's definition, the concepts and principles of learning, right? So we all know, and that's why we want to come back to those terms that are more accepted right now in society for many reasons, right? So we can say the science of learning and instruction and all of those things, but I make a point of making that kind of half joke, because I find myself doing that with new hires when they walk in, some of which were already RBTs. And I'm just explaining the basic interaction that defines everything we do, aka the science of human behavior can tell us this one thing, that behavior is a function of environment. But when we say behavior analysis and being a behavior analytic scientist, now we're infusing the natural science approach on top of that, right? So meaning we're not just saying what we learned from our theory and philosophy foundation, what is decades of research has demonstrated in experimental research in the lab with humans and non-humans. Now we're going over into that whole land of measurement and land of socially meaningful changes, So I was happy you asked the case conceptualization, question, Shannon, because that's why my language around this has changed, is because we've realized that there's value in taking the time to describe these differences when it comes to explaining to someone, here we are ready to try to help you. And if we don't understand what the foundation of what we do is, then we're going to get caught up in some real problems when it comes to the case conceptualization process. So I was really excited that you wanted to talk about that, because I really want to hear from Carrie and Nisa and you in terms of how you guys look at case conceptualization, if you don't mind. that made sense. I'm going to keep saying
Yeah, I'll jump in. You have shared with us an article that you've submitted for publication. So thank you so much for that. And, I really appreciate so much that you've included in there. But one thing around case conceptualization specifically that it seems little, I think also given our history, but I've come to realize that this is something that needs to be yelled from the rooftops. Is it has to start with a more comprehensive assessment. And you include that with respect to your comprehensive assessment of like risk and what risk, the definition of that is, but also even just, it's not just one assessment, right? It's not just one tool that you use. It's a battery. And that selection of what is going to be included in this battery is completely individualized. And I think that the more times people can hear that and see that, and that it's not like we just use this and we only use this, and that it's different types of data that are gathered from different types of assessment too, right? We have normative, we have, so there's those different tiers of assessment. Because if we can't even start off right, then when we get to the case conceptualization, we're already messed up.
Yep.
So
I was already messed up a long time ago, but I appreciate knowing that people are getting
I was going to say something else, but I remembered we were recording. So
I clearly am fine with anything being recorded that I say, so I'm just going to put that out there. But whatever you guys think, I get it. There's a bunch of contingencies in operation. These are you going to say something you look like you were good. I didn't want to cut off.
No, it's one of my favorite topics. It's a topic I speak to often in our training here, talking about assessments and speaking with Carrie and her team in that, our belief is it is a battery of assessments that, and I've said this, especially in trainings I did this week, we are not boxes to fill in a criterion reference assessments. We are a whole individual with so many experiences and accesses and families and cultures that we belong to, that the boxes are a frame of reference for the clinician, the teacher, to kind of start with where to begin intervention in case conceptualization, but bringing in multiple assessments, multiple interviews, standardized assessments, the diagnostic information from the diagnostician. I love to review all of that because what they're seeing at that initial diagnosis is going to be very unique to what the parents are bringing as the referral rationale. And in a lot of our podcasts, I've talked about the BCO white paper on decision making. And, I love that paper because it took into the way that I've seen treatment over the last couple of decades. And it really wrote it down in a way that we could take it, read it, and put it to our practice. How can we determine, because we're not just looking at the assessment that my one organization is purchasing for me, because maybe I only have access to this one criterion reference. It's my experience in training with that assessment or other assessments, my access to that assessment, whether that be the manual or digital. And then what do I do once I've opened to that assessment? How do I make that decision on where to hone in on the skills to evaluate when I'm sitting face to face with that individual? And then we also call them skyscrapers. So we're looking at those criterion reference assessments, which skyscrapers are appropriate, at least in this moment in time when I'm face to face with that child or individual.
Secret word number 1, speedy.
And then just to add to that, once you have all the data from multiple sources, how do you synthesize those data, right? Because it's not just how a learner shows up here, but it's the connectivity, connection, what word am I looking for here? But between all of those different sources, right? And it's the relationship. So it's the story, it's the moving motion picture, not just a one image data point, right? So there's a lot of analysis.
Yeah. Are we talking about interlocking contingencies? Are we talking about relational responding? Are we talking about on our part, right? Like meaning, as we all know, these are concepts and principles that are in operation all the time, right?
Exactly.
And so what I really love about what you just said, and it's funny, I was looking over here because we have notes on another paper that we just got back to do some revisions on, which is exciting. But and what did I wrote? I wrote here, CABA is the name of the organization that I founded, but I consult for now. So the note says at CABA, we avoid anchoring the case conceptualization process in a symptom reduction approach. Why? I didn't even think I was going to read this to you guys. 3 things. Number one, it's just what you just said, Nisa. So I won't even tell you guys the other 2. I'll go with you, okay? Because if not, then I'll just, give a talk for an hour, which I follow you because I know that's not what I'm supposed to do. Number one, why do we avoid anchoring our case conceptualization process in a symptom reduction approach? Why? Because our purpose as behavior analytic practitioners is not to reconfirm the identified diagnostic symptoms, right? So you commenting there on the DSM and the diagnosis, and we really have to take in that sentence. So our job's not to reconfirm those, right? So if any of the viewers, right, I do not provide diagnoses. Okay. That's not the work I've ever done. I've always worked with wonderful licensed people that do that. And I trust as a colleague that they have been well trained in the DSM and what they're supposed to do in order to establish these criteria. But thank you for referencing the paper, Carrie, my work and my focus, which I never thought it would be right now, because I didn't even think I'd be back in clinical practice, let alone dealing with, although 20-something years ago, you might want to use the term visionary here, that little scientist practitioner book, the subtitle of it was In the Age of Managed Healthcare. So I think everyone forgets that subtitle of that book, which is
I always call it a scientist practitioner. Yeah, exactly.
Entering the Age of Managed Healthcare. So I'm not a Steve Hayes student. Might have been married to some. We're not going to get into that. All right, but I will say that what Steve Hayes was talking about in the scientist practitioner model was the way he described it was 3 interrelated roles as a scientist practitioner. We're not talking about Boulder and PsyDs versus PhDs or conducting research. That's another use of that concept. When Steve Hayes came in and wrote this book, I don't remember the year right now. I didn't expect to bring this up, but I'll make it quick. He said there's 3 roles. You're a consumer of the available evidence that supports your practice, right? You're an evaluator. So that means, hey, CentralReach people, we're using measurement, right? So we are actually relying on that aspect of our science, which some people think that's all people mean when they say science is conducting and publishing studies. And as a behavior analyst, that's not our sole definition of it. That's one part, right? But our science is defined as a natural science approach, and it's based on very specific concepts and principles of learning. So there's an added level there. His last one, he says researcher, and actually I'm working on a paper with Michelle Wallace right now that we kind of want to revisit that and change that and recommend changing that 3rd role. Because if you look at not how he defines it though, which is funny, if you look at his definition, it just says disseminating the outcomes of your work. It does not say publishing in a peer-reviewed journal or presenting at a conference. Or that's just speaking personally. I took classes. Carrie knows as well. We were there. That it comes from somebody who did not have the concept of the term research that I've even faced lately when people I realize think that when I say science, I'm talking about research or vice versa. And I'm like, oh, I have to remember it's different. And I blame Steve Hayes for that because I know he didn't mean that, right? He literally says disseminating. So we're saying that we're a consumer, we're an evaluator, and we're a disseminator. Why is that so important for this discussion in case conceptualization and managed healthcare? Because he was a traditional couch therapist, not traditional at all, actually. I should be careful on that. So all I mean is his job was to work with people like us with more, and traditional is not a good term, but back then, especially 20 years ago, what we would say were more common psychological concerns, not even necessarily disorders, or even necessarily formal diagnoses. If they were, I believe he worked with a lot of people who struggled with depression. And I'm not trying to minimize those things. They're interestingly same as autism. We do not have a physiological marker for these diagnoses. I can't open you up and see your depression. I can't open you up and see your bipolar. I cannot open you up and say there's the autism. That is different than Down syndrome, Fragile X, right? That doesn't really matter insofar that we have to recognize that the diagnostic criteria are based on our observations of the person, what they say as well, right? And we know that those variables are influenced by 2 factors, what's constantly happening around them and what they're in a position to do. But anyway, what was brilliant was he saw that traditional psychotherapy, which he was not a psychotherapist, and most people back then probably would have thought he was a cognitive behavioral therapist or even didactic or whatever, something on the more behavioral side, right? We all know now that he's just a hardcore RFT dude, right? But I would just say a hardcore behavior analyst. He knew that the healthcare companies for traditional therapy 20 plus years ago were going to need data that demonstrated that the patients were making progress. So that entire book is teaching single subject design to traditional one-to-one therapy to be able to measure whether or not your talk therapy is actually producing improvements, So it's interesting when you think about that. So from the get-go, 20 something years ago, and he did it because of managed healthcare, he said we have to step back and look at our case conceptualization process, meaning case conceptualization is not just what is the appropriate goal for this person. For him, he was dealing with people that wanted to kill themselves. You can kind of pretty quickly come up with a really good goal and a really good marker for quality of life in that scenario. Don't die. All right. I think we're pretty good. Okay. Yeah. Now, quality of life, though, we need to add on to that. All right. Don't die and don't feel every day like you want to die. All right. I'm not trying to minimize, but I'm saying like these are the markers. That's not case conceptualization, knowing what that goal is. Right. And this little dude named Wolf said it a really long time ago, really well. All right. What's case conceptualization? It is the goal, the procedures, and the outcomes. It's all three. And the reason why we do the term, why we've gotten pushback, and people have said, Rachel, you shouldn't have gone down the risk path. And I love to come back and say, I'm not a professor and I don't work for anybody. So thanks. I don't know what shouldn't means, but I guess because that's usually what they come back to me with, that a lot of owners of big companies, this term is so obviously used in other ways. You shouldn't, or it sounds like you're talking about there's a problem. And I want to clarify two things. One, yes, there is no way for us to summarize the results of all of our assessments that come after the diagnostic, right? So diagnostic, now insert 25 million different types of evidence-based ABA assessments. Now we're supposed to make our recommendations, but as both Carrie and Lisa said, we don't have a framework for summarizing that. So our work for case conceptualization came first from saying, is there a way for us to take all of these and talk about them in one metric? And back to my first comment about me being very grateful when the second task list came out, because we were already working on this. And it's that key sentence at the end where they're talking about us needing to rely on our ethical obligations. But it's the very last sentence, and it says exactly that, which again was to maximize desired outcomes and minimize risk. And what we kept coming back to was, that's not risk to a procedure. That's included in that. And that's unbelievably important. So risk benefit analysis, not trying to diminish that. That's not the same thing as saying a risk-driven approach. Analysis is also different than assessment. I won't be this much of a dork. We're already back on. Anyway, so it's included in that, right? Meaning I'm not saying that we're not going to want to look at the risk associated with a given procedure, right? Stephanie Peterson, amazing work. Let's do a risk-benefit analysis on whether or not to do an experimental FA, of course, right? But it's different what the BACB said. It's maximize desired outcomes and minimize risk. That's risk to desired outcomes. So that's how we look at it. And what I laughed, Shannon and I were briefly talking, and let's be clear on what that means. We have to be careful because it doesn't say minimize risk. It says minimize risk to desired outcomes. And guess what? An individualized desired outcome might be for someone taking more risks.
Right, exactly. It could be risky.
Seriously, right? So we have clients that we have to work on that with. My own son, we have to work on that with him. He's doing his driver's test today. Apparently we made some steps. I'm terrified right now. There is an increased risk for a bunch of people while we're talking right now, okay? Highly increased risk is happening out there, and he's taking a risk. He's doing that to improve his quality of life, and it took us as the community to have to step back and say, okay, how do we identify the risk associated with him driving or not driving? And that's the beginning of a case conceptualization process. We know it's a goal for him. What are the procedures that we need to do to teach him this goal? And now how do we measure the outcomes of whether it was successful, him passing today and no one dying is my spiel. So that's it. That's all I got. But it's all three, so that's I think gotten lost a little bit. And I believe it's gotten lost because we've gotten away from what defines the science. We've focused primarily on the procedures and maybe some people, I don't know, have forgotten that why the procedures work, but that's not just like, oh, well, that's the science that told us and now we know these are evidence-based. If you don't know why they work, meaning the concepts and principles of learning and the science that defines us, when they're not working, you won't know how to change them. Exactly. So that's our big concern, is that case conceptualization needs to be rooted in the science of behavior analysis, which again means natural science approach, what we know about the concepts and principles of learning and instruction, And we need to be approaching it from day one with respect to not a goal in isolation, not the procedures in isolation, and not the outcomes in isolation, but every discussion needs to be across all three. And we believe it needs to be specifically with respect to, we're going to figure out what quality of life is for this person by talking about how we reduce risks to them having socially meaningful improvements. And we've seen the narrative change in that process. So
I love how you mentioned the quality of life for that person. Like, I think that oftentimes right?
You're the one who said it first.
I said it first?
You did. Oh. Yeah, I was, even though I go off for that long, you did. And actually Nisa did too. But you were the first one to say the individualized. And I laughed because I'm like, oh, I'm glad Carrie said that, because it reminded me it's individualized, meaning this person might need to be more risky. But go, I'm sorry.
Right. And that's, and it's also like, it also means that it's not me putting my assumption of what my quality of risk would be for you. It's like me finding out what it is for you. It has nothing to do with me. Like, I mean, at a silly little like metaphor here, I was actually having this conversation with Tim yesterday, and Tim Fuller. So Rachel, yeah, you're familiar with Tim, but we were talking about buying birthday presents. And I was like, my husband, Ethan, is so good at buying birthday presents that like, I don't even have to give him a list. He finds things that somehow I didn't know that I wanted it, but I really wanted it. And I'm so glad that he did it for me. I apparently am terrible. And he winds up just getting him stuff. And then I feel guilty that he went out and bought things for himself, because I would feel bad for buying presents for myself. But then, I wind up going out and getting a present, giving it to him. It's nothing that he likes. It's actually associated to my childhood and like romanticism around it. And like, oh yeah, we used to play badminton at my grandma's barbecues and they were amazing. He's like, he has no connection to that. Yeah, you should have. He has no connection to that. And even more so, he also is totally happy with buying his own presents, right? And so I bring up this silly metaphor just to show that like we cannot just put what we think would be meaningful for that person, right? We can't put that on them. Maybe it isn't, tying their shoes, right? Well, yeah, I mean, it's a good skill to have, but there's so many ways you can get around that. And that is not a priority for them right now. Maybe it would be down the road, but right now their behavior is like suggesting something else. And so I think it's really important for us to make sure that we take our own bias and our own history out of the equation when we're determining what quality of life means for one of our clients.
Well, not just our own,
I can talk
because Rachel and I had this conversation ahead of time too. When you come from the adult world and you are dealing with categories of risk that you don't necessarily have to deal with a 4-year-old, if that person is in services, probably they still have others in their life who are helping them make decisions and who are part of their team. And so what if that person is 27 years old and they have an interest in dating, they have an interest in having sex, and they have people in their lives. Sometimes it is a parent who just cannot come to grips with the fact that they are not a child anymore, even though they need the support. Sometimes they are living in care facilities where it's actually stated in the rules that you're not allowed to have sexual relationships. Then there's some very real questions like, does this person know how to consent? What about the person they're going to have sex with? Was that person going to be able to give consent? Is somebody going in the room with the two of these people before they have sex to make sure that everybody had that conversation correctly? I mean, there are so many huge questions that come in with that we only, as behavior analysts, as just part of the team, we only have to put our side, we don't just have to put our biases away, but sometimes we're helping people shepherd through them being able to put their biases aside as well. It's a really rough life for some folks with intellectual disabilities, especially who get to these age age appropriate decisions that have to be made. And you've got, would you want your mom coming in and making these decisions with you? I wouldn't. She still tried, actually, but it's not.
Yeah, I was about to say, Shannon, we have other moments of our, that we won't speak of our own anyway. Right. Some people that like to maybe tell us a little too much information too, which I go through with my son sometimes. You just said so much, you know how much I love this topic. So let me see if I can be concise, because actually funny, it started with Carrie, and I love that you just carried that through, Shannon, because I don't think I've told you this story. Carrie, you said tying your shoes, which is funny. I believe the last podcast I was invited, I just realized I did my own for a bit in the pandemic just because we were like panicking. And I'm like, I'll bring on people and have them talk about stuff because I've been talking too much. So I did not, it wasn't me. All right. It was just like a few, but I just flashed on this, hadn't thought about it. I had, I guess, when we were talking, that it's so weird that Carrie said tying your shoes. So 4 years ago, maybe, and I'm getting my timelines off, Amanda Kelly had me on her podcast, and she ended up labeling the it's so funny, this keeps coming up, labeling the episode Defining the Magic. I might get back to that for you guys, because I know I'm with measurement geeks, and it's a really fascinating story. And I believe that when we talk about case conceptualization, part of our problem in the field in terms of going into our procedures and our measurement and people thinking that's what it's all about is also that which defines our field from everyone else. So we've got to find a balance. But back then we had a moment where we were talking about similar topics, social significance, socially meaningful. And Dr. Kelly said, oh my gosh, Rachel, she was lovely. She's like, you're so right. It's, in Hawaii, we will prioritize using your chopsticks over tying your shoes. And I'm like, exactly. And then my moment was saying, yeah, you're right. Like we as a society have decided, and this is 4 years ago, we as a society have decided to define that which means quality of life for a child. Okay. Mm-hmm. Who the heck am I to make that decision for an adult? Mm-hmm. This would take 6 hours for us to wrap that story up. I'll give one little piece, which is I've kind of figured out who the hell am I to make that decision for a child as well right now. So I can go down that path with you guys, but I'm going to bring back the theme of it. Which is this notion of bridging the chronological to functional age gap. And I think that's an easier way for us to talk about how our process in ABA with respect to traditional ABA, and I don't like that I have to say that, but I do for some of the funders because we do different service lines we have no longer CABA, but CABA has like 6 different service lines. They're all based on behavior analysis. They're all ABA, but when you're talking, sometimes they don't understand that because it's not a child diagnosed with a specific diagnosis or whatever. So anyway, I say traditional just sometimes to get through that a little more efficiently. And I hope I didn't lose my train of thought. The thing just completely knocked me off guard there. Wait, what were we doing? Somebody help me out. I can do this. Oh no, I don't. Chronological, but no, wait, it's the same thing. You're right. Never mind. I got it. Thank you, Carrie. All of the assessment procedures that, not all of them, but the majority that we reference right now, and I did this for an organization once. I said, let's go back to the American Academy of Pediatrics, right? I'm an author on the almighty skills for CARD, by the way, Nisa, and I laughed when you were talking when you first started, because I said back then, I am worried that this gets released, that you're going to have supervisors that want to fill in the empty box and are going to get further and further away from what we know, and I'm even an author on it. I remember saying it at the time, And now, over the years, we started saying, all right, let's look at the developmental milestones. Now let's look at the VB map. Let's look at VINE. Let's look at a bunch of other stuff. Let's see if we have some agreement on these. And now let's look at someone's chronological age. Let's say, okay, they're chronologically based on their date of birth, 6 years old. Now we're going to do all these assessments to determine their functional age. And I don't mean my tone is terrible now. This is actually like really massively awesome for many people and brilliant, just by the way of the people who came up with this, by the way. We're going to now say, okay, all of these batteries say that even though they're chronologically 6, they're functionally 3. So that's where a good ABA supervisor should be starting their case conceptualization process, is to say, let's bridge that gap, right? What I've learned over the years is I might not even be teaching them to use chopsticks or tying their shoes, all right? Patricia Wright has a great story about this. If you guys haven't heard it, about her first time of wanting to come in and intervene with an individual who was not self-feeding and had some indices that they might be able to, but this was a non-ambulatory person that was going to be non-ambulatory for the rest of their lives. And she tells the story very well. I don't want to steal her story, but it's such a good moment of realizing that quality of life for this family that knew they were going to be taking care of this individual, I shouldn't say it like that, but be fortunate enough to be a part of this individual's circle of support for the rest of their lives, knock on wood, that's what's so scary, is who goes when the love circle goes away. We all know that, right? It was the feeding process, right? Mm-hmm. So that comes a little bit back to what Shannon said too, which is the difference of our work versus the medical field in case conceptualization. There's many differences, but the number one difference is we're not coming in and looking at a physiological symptom, and therefore we cannot measure our success based on reducing that physiological symptom. And there's nothing wrong with that. Dr. Wallace and I talk on a regular basis. She's a survivor of breast cancer, and we always, like, whenever we seem to talk, we even publicly together, we come back to me saying, I'm cool with a medical doctor not caring about your quality of life. And I'm like, oh, I should clarify, my dad was a medical doctor. It's not that they don't care, okay? But they're going to define your quality of life in a very specific way. And that's to reduce your risk of death. That's their job. And like, whenever I'm with Michelle, who went through that, we're both like, I'm good with that. You good with that? She's like, I was good with that. We're like, cool. That person's goal was just to reduce your risk of death, right? When we're doing this and we're talking about all the work that we're doing right now, that's not what we're talking about, right? So it's not just that we can no longer look at bridging the chronological to functional age gap in isolation. We also need to look at what the community of support is for this individual, what it is right now, what it might be in several years, and what it likely is going to be. And that's hard to project, but we need to do that with the caregivers. I'm not saying us on our own reading stuff. I mean, have that, and the individual, when possible, have that direct conversation. And Shannon, I couldn't agree more. The reason why we took the risk approach is that now we can step back and say, okay, we can identify quality of life for you. Let's say it was an individual that was demonstrating a ton of indices that having sex with someone was very, very important to them. All right. If I am the provider in this scenario and I can see that all markers of quality of life are indicating, and we're now starting to see some potential risks, I'd like us to catch it earlier, by the way, because the way we do it now, then we end up having to deal with it when there's a serious problem, right? When somebody's broken into someone's room in a residence and some non-consensual act of sex has happened. Coming in with a parent and barking all of that from day one is probably not the best way to build a good clinical relationship with them or rapport, right? So what we've learned, and it took us years to do this, because we did one of my last doc student, we did a study on we did a basic experimental preparation to try to imitate what do we say? We said it was demand delivered versus opportunity based, because Jack Michael at one point, there's one sentence that says the question is the conditions under which a demand becomes an opportunity. And we were like on this sentence. So we did some basic, I think we even did like a stimulus equivalence preparation, but what we did is it was real parents of real clients, and we presented supervisor instructions to them as either demands or opportunities. Meaning, if you don't do this, your child might end up in a non-consensual, horrible situation and have an STD, right? Okay, like, boom, like, right, here we go. Opportunity-based, if you do this, there's a really good chance that they could have a higher quality of life and be happier. And right, so interestingly, most parents identified that they prefer the opportunity-based, but we saw transitivity emerge faster on demand-based. Now, that doesn't say anything for fact. Most people don't even know what I just said, but that just, I saw Carrie was interested in that. So
on those things.
Back to Shannon, I can do it quickly. When we do a risk-driven approach with everybody involved with an individual, we do exactly what Shannon said. Okay, this seems like something that is preferred to the individual. Let's all be clear on all the things that we need to do to determine that and define that. That's going to be part of our assessment process. We're in the intake right now, right? But we were just saying, based on the things you've said, we need to go confirm this. And obviously that's different with the level of vocal responding from the individual, et cetera. So we know that. But right then we're able to start the conversation with saying, okay, so if we identify that this is preferred for the person, it's important to also know what your preferences are, mom, dad, teacher. And I had this conversation with my own son at one point. We knew what his preferences were and his goals for what he would define his quality of life as. And he said it very clearly to me. And I'm so happy that there was number 3, because it was drumming, gaming, and making money. So I'm only happy with number 3, not because I want everyone to make money. That's not my value system at all. And
take care of himself.
And at least you can pay for the gaming and the drumming. Exactly, right, Carrie? Yeah, I was like,
all right. Pay for 1 and 2.
Right? I was like, I can work with this, okay?
Yeah.
But then we sat down because I was like, all right, those are your goals. We know what the resources are that you need. We break risk into several categories. We talk about resources, people's characteristics, efficacy, and safety. Not several, it's 4, but when we went over to characteristics, which is our skills, our challenging behavior, our preferences, it's his goals. It's about him. So I was like, cool. All right. We already know what your challenging behaviors are right now. And we should talk about it. Let's get through that a little bit. All right. You've identified some potential skill deficits with respect to applying for a job, driving. This was months ago, all these things. Great. We got through this. And then I was like, cool, my turn. This is still all about you, but I clearly need to be part of this, right? Which I laugh when we go back to people being so annoyed at parent training goals. It's like, if the person's there, they're in the environment. The only way we know how to change behavior is to change the environment. So we are not trying, we have to get back to the science for that. I think the more we avoid that, the bigger the problem we have, because then we can't explain this. And if that's a problem for someone, great, but we need to be able to tie it back. Not great, but okay. Meaning but we can't have a dialogue about how we have to talk about potentially changing your parents' behavior as part of your goal if we don't understand that basic thing that I started off with, right? But my story with my son was me saying, cool. So just a heads up, my preferences are that I raise children that are making meaningful contributions to society. So we're going to probably face some problems over the next several months, but I'm here for you and we can do that. And I'm glad I had this opportunity just to put that out there. And honestly, Shannon, I joke, but we've seen a change even with the families that are heavily, let's say, just against their child ever having sex is the most extreme conversation. But when we've been able to come in this way and take a more structured approach to talking about maximizing desired outcomes and minimizing risk to those desired outcomes, it starts to change the dialogue. Because if the parents' desired outcomes, they still have them out. They don't even want to talk about sex, right? Some of them, we don't want to talk about that, but I can tell you all the other things I want them to do, right? Mm-hmm. And that gives us the beginning of starting to say, well, if we don't deal with the massive increase in masturbation that's occurring right now, that's a risk to everything that you just told me are your goals. And so we need to address that because that's a risk to maximizing our outcomes, so that's really what we need.
Secret word number 2, grown.
I hope I'm not taking too long. Sorry, guys. It was
No,
your fault. What you guys told me.
You're great. I think that what you are describing, as I was reading your paper and again as I listened to you talk, is very much in line with person-centered planning. So behavior analysts out there, if you have never been through a person-centered planning process, a really well done one, I recommend that you do that. Mm-hmm. It walks you through this, and you don't have to do it by yourself. You get to do it with a group of people who all are bringing their own skills to the table. You're talking about the person's goals, plus the obstacles to getting there, the health risks to doing it. And it opens conversation, and it's not meant to be a one-time thing. Sometimes those parents don't move in that one, but as time goes by and they start to see these smaller goals get met that just introduce a little bit of risk at a time, then they become more open to it. They feel safer and they're willing to engage. And it really helps with relationships among the interdisciplinary team members. It helps gain some trust from the family and the client in the people who are working with them.
That could be it's a love, and you just made me realize, I have a ton of credit to give to many people in Southern California. Thank you, Shannon. I can't wait to make a couple of calls after this. I bet. Oh, seriously, 6 years ago when I got a phone call from Regional Center, 2 different major phone calls. One was to start the first severe problem behavior service line with the Regional Center system that meant we were doing ABA 24 hours a day, 7 days a week. The second call was 1 to 2 in their homes. The second call was 1 to 2 years later, and it was, will you open these homes that are ABA based, that are actually community homes, and do this work? Long story short, Shannon, I hadn't thought about it. In those first 3 years of CAVA launched 8 years ago, I was thrust in the traditional DDS system, and I actually worked with some of the leaders in person-centered planning. We actually gave a talk about 6 years ago, I believe, at CalABA, which was about ABA and person-centered planning. And Shannon and I did not talk about this, but I pulled up I think it's about a dozen key components to person-centered planning. And it's not trying to do we know so much more than you guys. but I wish I had it in front of me. I wish I could show you. It was interesting at all, right? It was how can we contribute as behavior analysts to this process, right? Like, what do we bring to the table? Because they clearly have been doing it a long time and doing it really, really well in terms of how people are talking about it and feeling. Now, we know you can't base whether or not an intervention or approach or something is working unless we have, And when you look at the 6 steps of the purpose of person-centered planning, they're actually, I don't want to say claiming because that sounds mean, but they don't have the same training as us, but meaning they're using that language. Like, so, and they don't have the same training and skills. I believe that's what we can bring to the table is the measurement component. And that's what was funny about the defining the magic in the full circle. That was a story of me being called in as a consultant to a floor time agency. The gentleman who owned it, his mother founded it. She was an SLP, but she was trained directly by Greenspan. He was certified as well. And this little thing called the BCBA seemed to be becoming real important for his contracts in Los Angeles coming up on 2008. And actually, Megan Kirby at the time roped me into a meeting that I had no idea what I was going to. It was always like that. As department chair, I was off visiting practicum sites, and I would just get in the car and be like, where are we going? And she'd give me like a quick rundown. Like, that was my day. I'm like, who is it? What's going on? How many employees? Like, boom. And she goes, this right away. So he's a really nice guy. And I kind of knew right then, I was like, why are you starting off this meeting that this is a really nice guy? Like, what, where are we going? And she goes, so he has something. They got like 100 therapists and they want to improve their reliance on ABA. And I was like, cool. Like, that sounds great. Together, they're DIR. I'm like, sorry, what? So it's 100 floor time therapists and they want to switch to ABA. And I was like, awesome.
Okay.
Let's do this.
The challenge I take.
Yeah. Long story short, and funny, Wolf was right. That's not funny. That would be sad if he wasn't and we were all here. Goals, procedures, outcomes. We actually had the same goal, meaning we, like, I'm kind of separating us, but like as BCBAs, if I were to come in and look at these kids, and I was listening to these 100 developmental certified floor time therapists for the year and a half that I did this, I'd be like, we all have the same goal. We want these kids to have an improved quality of life. All right. I don't know if you guys are getting the same outcomes. You're not measuring it that way. I don't know. So instead of doing our traditional, when I came in and was asked, we would almost, and I think you guys will agree with me, right? What's the old school ABA training? Introduction to ABA. What is autism? What is the 3-term contingency? This is reinforcement. Now let's talk about preferences. Here's a discrete trial, right? I'm mocking myself, right? I've made many of those. I'm not mocking, actually. What I'm thrilled about, it was the first time that I knew that they were against somebody coming in and trying to introduce ABA and change the entire focus. So I knew I shouldn't start off with what is ABA. All right? I was like, that's a pretty obvious one. But I knew we had a lot of the same shared values. And when I really had to dig into it, I was like, ooh, this is the first time I'm going to switch the order. I'm going in with what is measurement. And I want to say, you guys love the work you're doing. You're doing great work. Let's talk about this thing called measurement. Because if you want to keep doing it, we're going to have to demonstrate that what you're doing is working. And fascinatingly, some of what they were doing was working. And we actually scored a bunch of videos using this amazingly complex thing called ABC data recording. And fascinatingly, when a bunch of certified floor time therapists were working with the kids, there was some pretty clearly identified contingencies in operation, so it's back to the measurement part, but that impacts our conception of it, right? That's the problem. And so
I love the shift to measurement, obviously.
Yeah. Go ahead.
Yeah. Well, this brings in, like, when this is something that, again, our history, we've done a lot, but it's and I feel as if behavior analysis only has, or the majority of clinicians, I would say right now, only has a good grasp on like 1.5 of these different levels of measurement. But we have micro level, we have meso level, we have metadata, and we have macro data, right? And so we're really good at the micro in the sense of we're constantly looking at, okay, what's, how is the learner improving their performance on this one particular target or something that's very molecular, right? And then we have our macro, which we're okay, like maybe a B- at with regards to our assessments, because again, not everyone does the whole battery. Sometimes we're stuck with one, or we use the assessment as our intervention too, which is not best practice, right? But then these in-betweens, I think that we need all four for proper case or program evaluation, right? Not necessarily like, I think it helps to guide the case, but to actually know if this is working, we need to know like, what are some like short little like somewhat a little more proximal than the macro data that are down the line that I don't assess until it's like every 6 months or once a year. But that helped me, like, they serve as a barometer to knowing how like those data are going to turn out. And then the metadata, you know, our data about data that are suggesting like, okay, like at what point can I make a lot of changes for this learner that they're going to be agile with and that will be successful with? Or is there too many changes for this learner, right? Or how is the how is the efficiency and efficacy of my therapists, right, and their intervention? So like, we need to make sure that everything, when we form that case, that we have something slotted in all four of these different levels of data, so that way we have a system that's already set up to evaluate how everyone's going through it. There's a diagram.
4 levels of data. It's not your 4 levels of data. I know you read my paper, so it's not. I didn't think I had this here either, but it's interesting. It's your 4 levels of data, but I'm telling you, and we just are trying to get our research as fast as we can out there, but these are the 4 domains of the RDA. It's a new visual of it because we used to just do that, and it's usually not, I think, in grids. And this was actually, we met with Amanda Ralston recently, and we were talking about it, that I had pushed back on saying that I wanted us to do it differently. That's safety right there. You got resources, you have characteristics right there. There, efficacy. And when we talk about it, when we talk about our measures, the reason why efficacy, I feel, I can tell you guys the safety thing later, it's later, but I like this visual, I agree with it. But the key that I was pushing against was anyone thinking that one of these is weighted with any more significance than the others.
Right.
Now, as a practitioner, I finally got sold on this because I'm like, all right, we know that we have to come in with safety because we're ethically obligated. So I'm fine with that. And more often than not, when we look at, are there any safety risks? If there are, and there most often are, it's going to be related to either resources, characteristics, or efficacy. So I'm fine with that. But Carrie, your example right there that's case conceptualization. So I always say, this started for us with resources. I heard a rumor that apparently some agency owners and CEOs, luckily I'm not a CEO anymore, but will encourage staff to, and nor does CAPA do this yet, even though I'm not a CEO, I should clarify, but to take on clients when they don't have enough staff, right? I used to have this like kind of funny moment about that where I'm like, I've heard this issue, and I'm like, I just don't get it. No. Yeah. Wake up one day running 4 residential homes in the middle of a pandemic. You suddenly look at that issue real different. And that was my moment of being like, ooh, I've been talking smack about people taking on clients without enough staff for a long time. And I might have clients with no staff. Like, this is just a fact. Like, oh my goodness. And that's what started changing it for us, Carrie. And where I realized you guys can't go get mom and dad's availability after your intake and assessment and now look at everything that you just thought of and have that be a variable. I'm proud of you that you're at the point where you realize that you're even need to look at that with respect to your recommendations. You needed to look at that with respect to your goal selection and your procedures and your targeted outcome measures. Why? Because parent availability is a risk. It's a risk. To what? Maximizing desired outcomes. What's our job? Maximize desired outcomes, minimize risk to desired outcomes. So an individualized goal for that person simply cannot be made without looking at the relative risk of the resources that are available. It's a fact. And the efficacy one, I love you, Carrie, of course, because you're way more advanced and trained and an expert in measurement than I am, and I'm not. That's not available. That's a fact, okay? And I love having colleagues that I can respect and learn from. So it was really nice to hear from you there, because I like to say we have the same training, so I understand it a little better than most people would, right? And I'm the one pushing the efficacy domain with a lot of our staff, and they struggle with it because it's really more of a predictive at the point of intake and assessment. It's more predictive, meaning you have to kind of stop and say, what's the likelihood that it's going to be implemented with integrity, et cetera? But it's still part of the narrative, Carrie, exactly. And that when we keep the risk-driven approach at each step in our progress review, not just intake and assessment, because you're in assessment constantly, that conversation has been over the last few years as some of the individuals have progressed to the next level. It's been awesome, Carrie, I got to tell you, because now we can talk about, again, efficacy is not just whether they're implementing the BIP correctly, right? It's efficacy with it. That's huge, but it's across the entire thing. Are we demonstrating that what we're doing is and is the process that we're going through to demonstrate that introducing any additional risks based on the resources, their safety, the characteristics? Because I can tell you right away, there are a lot of safety concerns with great data collection. And I know that
100%.
from being the chick with Michelle Wallace in a Reno mall 15 years ago, running my master's thesis by bugging the ear devices with real parents and children, elopement no less. So there's a lot of high-paced running, okay, towards exits. And this is before people walked around talking to themselves. So my professor had to go like 10 feet behind me to let people know that I didn't need help, that I was actually helping other people that were 20 feet in front of us, right? But
there's something similar at a grocery store,
right?
Yes.
So we were doing it, right? So I was embarrassed, it even says it there when we said, ooh, the RDA. I'm like, I spent years saying, don't come up with another acronym or name. And now I'm like, oh no, I think I'm gonna push this. I'm gonna push it because it just seems more and more like it's bringing these issues in an easier way for us to talk about it, Carrie. So thank you. You just helped me.
Yeah. And Rachel, I want to pick out something that you said. You said we are constantly in a state of assessment. I want you to elaborate what that means, because I think everyone needs to hear this point.
And it's so we are in such different worlds, and that's so odd to say that, right? In this tiny little field. And I realize that on a regular basis. It's funny. When I was a professor, I stopped teaching intro to ABA, and any of the current executive team at CABA, most of which are former grad students. Anytime I'm doing any kind of mentorship with a team member who's struggling with working with a direct staff member or a parent, I often come back to the story, and every time I say it, like, anybody who knows me is like, yep, and she should have stopped teaching that. Yeah. And it's that, like, I had lost perspective on like how to, right. So I get like my other students that I haven't been a professor in many years now. And, I had a couple CABA leaders a couple years ago being like, don't come to my class. You'll never want to wake up in the morning. I'm like, okay, that sounds really depressing. Like, what is going on with the students? Like, I don't know. Like, so when I hear this, I'm like, oh my gosh, Gary, I have to explain that. All right. We have to explain that. Well, right.
Well, and I just think it needs to be like direct. Like, that's why I wanted.
You're going to be able to say it better than me now.
I didn't want it to be glossed over, because again, like, just based on contacts with our field, again, because it's a profession now, like it's an industry. The concept of continuously assessing is like.
And I'm going to take this in a different direction. Thank you. I hadn't done this yet. Let's see if I can do it. I just thought of it. That's funny. Okay. So part of why I started talking about medical necessity and managed healthcare was, besides the fact that that's clearly a big topic in the change in our professional landscape, part of it came to me from, and it's a small family and owned operated company. So we're not dealing with the private equity thing. But when I heard people start to now publish more on the potential problems with private equity, which of course there's problems with private equity. I always say potential. I'm such a side. I think the potential. But anyway, there's problems with everything, for the record. And a lot of the problems that are getting identified with private equity, I feel strongly there's a misnomer there, because I feel like those are problems that would have happened anyway because of the transition to managed healthcare. So it's not that diminishes the fact that it's a problem we need to deal with, but let's figure out where our lens is. Because if we're going to go in on this, years of effective advocacy work made it so that this is happening now, right? So that's a good thing. So can we stop and say that the advocacy work was, and increase access to medically necessary care is a good thing? So if we can stop and say that's a good thing and figure this out, and what happened to us was, maybe there's even added benefits of us now having to stop and look at this medical model. So that's really me. I'm not in the whole world of, everything with managed healthcare. I don't deal with contracts. I'm not getting upset with an insurance provider. I don't do that. So I can geek it out more conceptually. And interesting, Carrie, I believe this is another potential, and I'm saying this because we're in such a westernized medicine society. By the way, Nisa, as a formally certified yoga instructor and kickboxing instructor, my dissertation was self-control and impulsivity. I would have never been a certified instructor if my dear friend in grad school didn't open a fitness studio and have everyone's BCBAs like on the wall. All right. And I needed repeated practice on not talking so fast. It's the year that I was teaching freshmen intro to psych, and it's 8 a.m. and I'm up there with 150 freshmen like, so I was like, yeah, I'm actually not a yogi, but I'm pretty sure if I have to train to become a teacher, I'll slow down. So anyway, sorry. Medical model, Carrie. I think the easiest way, I know where you wanted me to go, but I believe that we should say to people probably when this problem comes up, because let's just jump to that. You're asking me the question because you're clearly interacting with practitioners who don't understand this, right? So let's stop and say, hey, if you had a tumor that was cancerous, don't you sure want them to continue to assess it?
Right. You don't wait until
I'm being kind of half serious.
I really hope that surgery works.
It's the first time I've really thought about it, honestly, Carrie, because I'm always like comparing the two now. You guys have seen more than the listeners have, because who knows if the paper will be published. But, you know, we walk you through like a medical model symptom reduction approach. There's nothing wrong with that, right?
Yeah.
But now let's look at what the positives are of that. So thank you, Carrie, which is MEMS teaches us the importance of saying we are here. Their thought is that we're here to reduce symptoms to reduce risk of death, essentially, right? So the problem I'm worried about is then people say, well, we'll just teach them we're reducing symptoms to improve quality of life. I believe that, especially given the change in the values of our society, we might not want to be reducing a symptom to improve quality of life, because quality of life is for that person and their immediate circle of support. And now we have to start to look at that. So that's kind of that whole start of it. But it all is coming up because we're now in bed with a pretty awesome symptom reduction approach to helping humans just for physiological problems. So it is the same answer. Why? Because you have no idea if what you're doing is working. So now I'm kind of, thank you. I'm going to use that one.
Yeah.
So,
and that it's not just, you don't have to like, one, we don't want to wait, but it's also doesn't mean that you have to run the big mama every month, right?
No,
like
exactly.
That brings it back to that different layers of, the different layers of assessment. If like being successful with riding the bus is something that is, the whole team was like, this is something that's important. We're not directly working on that now, but that it is a goal of ours, then you need to have that some sort of measurement to monitor. Is the impact that we're making down here on the ground floor actually moving the needle at all on something that has been identified as socially significant to this,
let's take
person and this family?
Yes. And
I want to speak to that from the field perspective of having worked in managed healthcare in an organization where you have a large case and then those kind of 3 month, 6 month, 1 year assessment requirements, where very much to what you're saying, Carrie, those different levels of data are going to inform not, I need to wait till the 6 month reauthorization to run this assessment. It's that, have we moved close enough into each of those levels of data to open up that assessment and be evaluating it consistently and have it, I made it a part of the practice for the BCBAs I supervise to just have the treatment plan open, have the battery of assessments open, and every time you pop in, just check on the total skills that you can look at across the week. So I'm going to see you Monday, Wednesday, and Friday. Monday, this is what I'm going to look at when I come in. I'm going to check in again Wednesday on these other skills, and then Friday, and then when I go in to see if we've made that progress, I'm going to evaluate that data further. It has to become a part, as a clinician and a practitioner, of your own schedule. Instead of just going into the session completely like, I've got this on my schedule, I've got to go in for 2 hours of 97155 or 97156. I'm going to go in very pointed to what to evaluate. I'm going to open up the plan that I've submitted and make sure that I'm moving in the right direction for this individual. And providing it in a way, especially for some of our new practitioners, that it is scheduled for them so that they can see what should they be looking for when they go in, versus I'm going into session, I have no idea how I'm going to evaluate the goals I submitted back to what I'm seeing in this child in this setting.
And this, I have so much. Yes, and it's the notion of I can handle this. Okay, so like the notion of like maintenance data as well, right? Like, okay, I hear you. Let's put them on the schedule. We have. Yeah, it's too much. And I know we're out of time soon. So yes, and I totally agree with you. And what worries me though is again making sure, and I know this is going to be a ridiculous amount of work, but I know we're all in it. is that they understand the why too, right? So
Yeah.
let's do it. Let's get them scheduled so we can have them coming in contact with the contingency. And then what are we doing to push through the why? Because Carrie's example is such a good example in terms of, right? What would a lot of employees say? Why do you have to, okay, your schedule says you have to go in on these 2 times and you're looking at these goals. Let's go with that. Right now, we're going to say that their schedule also tells you how often you need to collect maintenance data on previously mastered targets, right? I'll go with the usual language. Sorry, sounds so annoyed. Sorry. I'm at that point, who's the person there that's making sure that they understand that if we had data to demonstrate that we mastered successfully being on the bus, that's great and all, and that we're doing maintenance data and we can take probes once a month to say, or maybe if it's an indirect measure, that's okay, because guess what? Parent report of whether their kid got on the bus is probably going to be pretty likely accurate. Okay, we can have an argument about this. Okay, but I'm okay with that. Like, and if we see it decreasing, that's where the why starts to come in, because Carrie's point is so important. We don't just then suddenly need to stop and say, okay, now we need to go back in and brush up on some of our procedures with getting on the bus that we used before. We probably need to look at what the hell else is going on right now. Excuse my language. Sorry. That could have possibly contributed to that. Now, we're not going to go down and do some, psychotherapy. No, we can identify if there's been any massive changes in this person's environment. We can look to see if we're seeing changes in any of their other skill acquisition programs. That needs to be looked at as a risk to get everyone involved to look at it that way. So if your maintenance data are suddenly not demonstrating maintenance, that's a risk. So now what do we do? So that's how we've done it, Nisa, just so you know, is that's why we drove so much into it and why the word approach was so important, because I knew that if we said a risk-driven assessment, it would be something else that they needed to do. And don't get me wrong. 25 BCBAs. I think we have 19 individuals right now that are pursuing fieldwork experience. 250 staff members. So, I'm not saying this is that we've by any means, all our staff aren't even doing it, but just the beginnings of pushing it out there and making it more embedded in everything. But yeah, you have to start with the schedule. There's no doubt. We're lucky because we implemented an academic model at the organization at CAVA that I help now, where those guys have access to a clinician with, I always say, a more seasoned clinician. And I'm working on my language. And I'm like, I like things spicy. I don't know. So I'm more excited. I don't like this. Okay. But somebody who's been, I don't want to say longer because that doesn't mean you're better. Anyway, we got what we refer to as executive advisors. Now they used to be senior behavior analysts, but those guys have 5 BCBAs. Those guys have a 45-hour billable requirement a month. And I look at them and I say, and other than that, I just need you to make sure these 5 BCBAs are doing what they're supposed to do. And we say you have to have both monthly performance reviews. No, you have to. They do have monthly performance reviews, but that's separate than their ITP meetings, their individual treatment planning meetings. So I hear you, Nisa. I do want to push it out of just telling them what they need to do in session with the client, and how can we get more agencies getting them in contact with one-on-one time with a mentor to flush through it outside of the session.
Secret word number 3, centered.
Thank you. I want to say thank you to Rachel, because honestly, you're one of those people that as you talk, it's like I can visually see your mental map. I can see all the way everything is intertwined together. Everything is connected. It's enviable. Thank you so much for joining us today. I wish we had another hour, because I feel like we could always go that long, but unfortunately,
that would be easy to fill that hour with Rachel for sure.
I'm like now. I know. I'm like that. I wish we had another hour so I could practice not talking too much. So please do not go back and data analyze my total intervals versus yours.
Idea. We could practice our assessment.
Yeah, no.
Thank you again for joining us, and everyone, stay tuned. You'll hear a summary of how to get your CEU, but for now, we're going to say thanks for joining us, and we'll see you next time.
Thanks for watching this episode of the Behavioral View. To get your CEU, follow the link in the instructions below. You can then go to the attendance verification quiz where you'll enter in the secret words and pay the CEU fee to generate your certificate. If you've already done the work, you may as well get the credit.